Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com.
The DEA has changed the rules on hydrocodone-containing pain relievers. What does this mean for people in severe pain? This is the People's Pharmacy with Terry and Joe Graydon.
Narcotic pain relievers are the most widely prescribed drugs in America today. Drug diversion and abuse have become major societal problems. But for millions of people in chronic pain, there will be new barriers to getting their prescriptions filled.
A pharmacologist explains the new law and how it might affect you.
We'll also talk with Dr. Tironi Lodog about vitamin D. With winter coming on, getting vitamin D from sitting in the sun is hard. Do you need a supplement?
Coming up on the People's Pharmacy, the health news that matters to you, plus your calls and questions.
First, this news.
In the People's Pharmacy health headlines, new research may bolster the use of turmeric, the yellow spice in curry, to fight inflammation. The presumed active ingredient, curcumin, has shown remarkable activity in tissue culture studies suggesting it could be beneficial against arthritis, Alzheimer's disease, cancer, diabetes, liver disease, lupus, inflammatory bowel disease, wounds, and many other conditions. The trouble is that it's difficult to achieve comparable results in clinical trials because curcumin is not absorbed well from the digestive tract. Now, scientists at Ohio State have found a way to overcome that obstacle. They formulated curcumin in a nano-emulsion with castor oil and polyethylene glycol, the compound in the laxative Miralax. When mice were given this special curcumin by mouth, the compound got into the bloodstream and shut down inflammation. The scientists found that the treated mice had much lower levels of NF-kappa B, a pro-inflammatory protein, and less activation of macrophages. These immune system cells are important in fighting infection, but they can also contribute to excess inflammation. The investigators think that the nano-emulsified curcumin could eventually prove useful against Crohn's disease, diabetes, rheumatoid arthritis, lupus, and cardiovascular disease.
New technology at the laundromat makes wash day easier, but poses a poisoning hazard for young children. Starting in 2012, laundry detergent became available in pods, which are easier to carry around and far less messy than conventional powders or liquids. Sadly, the attractive packages have fooled some children into thinking they're toys or treats. Children younger than 3 years old are the most common victims of pod poisoning, which has landed more than 100 children in the hospital in the last 2 years. 2 children have died. The investigators recommend that parents of young children stick to conventional laundry detergents since these are less toxic than pods. They should also store detergent out of children's reach and keep the poison hotline number in their cell phones and near home phones.
Doctors have been debating the best diet for diabetes for years. In an effort to settle the argument, Australian scientists recruited more than 100 overweight adults with type 2 diabetes to participate in a dietary trial. The volunteers were randomized to consume a low-carb diet that was also low in calories, or a high-carb diet matched in calories and focusing on unrefined grains. Both diets were low in saturated fat. After 6 months, both groups had lost weight and improved their blood sugar, blood pressure, and cholesterol. The low-carb diet offered greater benefits in allowing people to reduce their diabetes medication and may be the best choice.
Television viewing may lead to overeating. This has been variously attributed to commercials for appealing, fattening foods, or to the sedentary nature of watching TV. Now, a small study of 94 college students shows that some popular styles of TV shows encourage greater food consumption. The students were provided access to snacks, M&Ms, cookies, carrots, or grapes. and their consumption was logged while they watched two different types of shows. While they watched the action movie The Island with multiple camera cuts per minute, students consumed 65% more calories than when they were watching the Charlie Rose interview show. The investigators conclude that most of us should avoid snacking while we watch television, especially if the programming is action-packed.
How much vitamin D is optimal? Nutrition experts have been debating this issue for years. Epidemiologists in England conducted a prospective study in which they measured blood levels of 25-hydroxy vitamin D in more than 14,000 middle-aged people. During 13 years of follow-up, the researchers found that vitamin D levels predicted subsequent mortality and illness, including respiratory disease, cardiovascular complications, and bone fractures. Those with the lowest risk of dying during follow-up were individuals who started the study with blood levels of at least 36 nanograms per milliliter. Although previous studies have hinted that too much vitamin D might be risky, this study turned up no evidence of increased mortality at high concentrations of the vitamin. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon. I'm a pharmacologist.
I'm Terry Graydon. I'm a medical anthropologist. Have you ever had a tooth pulled? Or perhaps you needed to have your appendix removed or some other type of surgery. Chances are you were prescribed a potent pain reliever such as hydrocodone. It's found in drugs like Vicodin, Lortab, Lorcet, and Norco. The DEA has just made it harder for people in chronic pain to access this medicine.
To find out more about this change in the rules, we turn to Dr. David Kroll, pharmacologist, former pharmacy professor, and current contributor to Forbes.com. He spent the majority of his career discovering drugs for cancer from nature.
Welcome to the People's Pharmacy, David Kroll.
It's a pleasure to be here again.
David, something happened. I'd call it a sea change. This fall with regard to very potent pain relievers, in particular one drug called hydrocodone. What changed?
Well, hydrocodone is a drug that's a member of a class we call opioids that are used to treat pain. And hydrocodone was one of the drugs that was available most freely when it was combined with another pain reliever like acetaminophen or aspirin. And we had a change on October 6th where the prescribing and the distribution and the filling of those prescriptions became much more restrictive than it had been in the past.
Why?
Well, it turns out that we've been having a major problem in the U.S. With addiction to prescription drugs. We continue to have our problems with illicit drugs. But in recent years, the overprescribing of opioid pain relievers, together with the fact that they can be taken from family members, taken from mail-order pharmacy envelopes, has led to a situation where we now have about 16,000 people in the United States dying each year because of overdoses, not of illicit drugs, but of prescription opioid pain relievers.
And now we're talking about narcotics. We're talking about a particular class, as you mentioned, like hydrocodone, known under the brand names Vicodin, Lortab, and Norco, but also a number of other brands as well as generics. How many prescriptions are written for these drugs every year?
This is fascinating, Joe. Hydrocodone combined with acetaminophen is the single most prescribed drug in the United States. Of course, most of these forms are generic, other than the brand names you mentioned. So the amount of dollars often doesn't show up in the top 10. But really, since 2007, hydrocodone acetaminophen has been the number one prescribed drug, on the order of 165 million prescriptions per year. This is in a country of 318 million people, folks. And there has been only one other drug that has been prescribed over 100 million times, and hydrocodone has hit well over that the last 7 years.
Why?
It's a very effective drug. Hydrocodone is so it had been previously subject to the least restrictions for doctors to prescribe it. And it's also very effective, particularly for chronic pain patients, as well as for folks like you and I. I had some dental surgery a couple months ago, and it is great for post-surgical pain, for 7, 10, 14 days, maybe a month if you need. And so it works.
And I have to assume that with, that many prescriptions being written, there are an awful lot of people in pain.
Oh, I think that's what's been most surprising to me in writing at Forbes.com is the number of patients who've written to me about how much pain they're in, how few alternatives there are, and just how much they need this medicine for legitimate medical purposes.
David, you mentioned that there's been a change in the way these drugs are handled, classified, etc. What was the change?
Well, Terry, I think what we have to do is go back to 1970 when Congress instituted the Controlled Substances Act. And this allowed the Drug Enforcement Agency, which we know as the DEA, to be able to place restrictions on drugs based on two issues. One is their addiction potential, and two is their medical use. And what the DEA did was, and Congress, allowed the DEA to do this, was establish a scheduling system of controlled substances, and the schedule goes from 1 to 5, with 5 being the least restrictive. And we have drugs in that class, like the anti-anxiety drugs, like Ativan, for example. Then at the other end of the spectrum, on Schedule 1, we have drugs with high degrees of abuse that have currently no medical uses, such as heroin, some of the hallucinogenic drugs like LSD, ecstasy, those kinds of things. And then the most restrictive class of drugs with legitimate medical use is Schedule 2. And this is where we have drugs like morphine, for example, the most effective pain-killing drug known to man. The problem is that these effective drugs have a high risk of addiction potential. And so the DEA restricts the distribution and the amount of those drugs that are available on the market. Hydrocodone was an outlier. Hydrocodone itself is actually on Schedule 2. But when it is mixed with a non-prescription pain reliever like acetaminophen or aspirin, it was allowed to be on Schedule 3. So what am I talking about? Schedule 3 drugs, doctors used to be able to call in. You could get a faxed prescription. You could get multiple refills. So each time you go to your doctor, you could get as many as 3 refills on a single prescription and get up to 2 prescriptions for a total of 6 months of drug if you're a chronic pain patient who needs it that long. Moving it to Schedule 2 has made it much more restrictive. Doctors can no longer call in or fax a prescription. They're only limited to providing a written prescription that the patient has to bring to the pharmacy, or in limited cases, if there is a secure electronic prescribing system like the VA hospital has, those prescriptions can be sent in electronically. But the issue, I think, facing chronic pain patients is you have to visit the doctor more frequently, and you can only get 1 month at a time, as opposed to a total of 6 months. And this has been a real burden on many patients around the country.
So essentially, you have to see your doctor every month.
Not necessarily. You have to see your doctor at least every 3 months. Doctors are allowed, under Schedule 2 rules, to write 3 one-month prescriptions per doctor visit. So in essence, a patient could, if the doctor is comfortable, and not all doctors are comfortable doing this, most are just giving out 1 month at a time, if they're giving any at all.
So in reality, it very well might mean that a patient who went to see the doctor every 6 to 9 months for their bad back situation or, some other chronic pain problem, now they have to go in conceivably every month.
They have to go every month or at the minimum every 3 months. And I've had readers tell me that their pain clinics, their pain doctors are charging up to $300 per visit. And I mean, these are very serious costs for folks who are on limited budgets.
So in addition to being extremely inconvenient, the extra time and, trouble that you have to go to see the doctor either every month or every 3 months as opposed to every 6 months, it's also an expense.
It is most certainly an expense. And, there are people who don't drive, who live in rural areas, who maybe don't have a pain clinic that they can go to, but just a single freestanding physician. And if that physician's on vacation, they can't get a written prescription, in the past.
And now they are totally out of luck.
They're totally out of luck. I mean, I had a reader tell me that their husband, who had dental surgery, was in pain on a Friday, actually had a situation where the pharmacy ran out of the hydrocodone combination product on a Friday, couldn't get anything on the weekend, couldn't get hold of the doctor. So the poor guy he had 4 teeth taken out, had to suffer through the weekend with nothing more than ibuprofen or Aleve.
Now, the whole point of this new change in scheduling for hydrocodone-containing products is presumably to reduce abuse and to reduce those overdose deaths. Will it work? Do we have any data?
Yeah, I think this is the major problem, Joe, and that is we don't know. We do not have enough science to know whether restricting the amount of hydrocodone combination products in the system is going to minimize abuse. And I think what's also telling is that the DEA is not required to collect that information.
Oh.
No.
They don't have to collect it. Well, if they don't have to, they probably won't.
Well, and that's been a major issue with Congress. Before this all went down October 6th, the House and the Senate had looked at legislation that would protect both the patients while also minimizing abuse, and it required an interagency partnership, essentially, where once a year all these agencies had to say, well, if we make this more restrictive, what is it doing for access to legitimate patients, as well as what is it doing for abuse? To be honest, most of the pharmacists that I've spoken with, most of the addictions clinicians that I've talked with say that this really won't affect the total number of people who are addicted to the narcotic drugs. It'll just shift them to other drugs.
And in the meantime, people in severe pain could be in big trouble. Let's put it this way. A reader put a subject line to me that this is both stupid and inhumane.
Dr. David Kroll, thank you so much for talking with us on the People's Pharmacy today.
My pleasure, Terry.
You've been listening to Dr. David Kroll. He's a pharmacologist, former pharmacy professor, and he's current contributor to Forbes.com. He has spent the majority of his career researching natural products that could lead to drugs for cancer. On our website, you'll find a link to his article about the new rules on hydrocodone-containing pain relievers.
We need to take a short break. We'll be right back, and we're interested in your experience dealing with serious pain. Do you take non-steroidal anti-inflammatory drugs like ibuprofen or naproxen? Have they worked well, or have you had any side effects? And what about hydrocodone? Have you used it responsibly? We welcome your stories at 888-472-3366 or radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like this podcast of the People's Pharmacy and want to continue the conversation, you can join us online at facebook.com/People's Pharmacy to share your thoughts or comments.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible by Red X Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
If you'd like to order a CD of this show, you can call 800-732-2334. Today's show, number 970, or you can find it online at peoplespharmacy.com.
Today, we're talking about the health headlines that matter to you. What's your experience with hydrocodone-containing pain relievers? We're also discussing the pros and cons of nonsteroidal anti-inflammatory drugs like ibuprofen, diclofenac, meloxicam, or naproxen. You can give us a call at 888-472-3366. Send us an email, radio@peoplespharmacy.com, or you can reach us by way of Twitter. We're at People's Pharmacy.
You know, we were talking initially about these very powerful narcotic pain relievers like hydrocodone, found in Vicodin. But there's this a whole other category of pain relievers that tens of millions of people take every single day in this country. And that's ibuprofen and naproxen, available over the counter. Advil, of course, you've seen the ads. Aleve. And they're also available by prescription. There's
diclofenac, which used to be available as Cataflam or Voltaren. There are actually probably 24 or close to it prescription NSAID pain-relieving drugs. But there are problems with the NSAIDs too.
Well, there are problems. We've heard recently about heart attacks and strokes associated with NSAID-type pain relievers. That happens in arteries, blood clots in arteries. That leads to heart attacks and strokes.
And there was a recent study that showed that blood clots also happen in veins, more commonly on people who are taking NSAID pain relievers.
Now, this is brand new information.
Yes,
because
it is.
We never realized that this was a possibility. These are called DVTs, deep vein thromboses. And when a blood clot in, for example, the legs, and a vein in the legs breaks loose and ends up in the lungs, that's a pulmonary embolism, and that's a life-threatening event. Just some of the concerns that we have about nonsteroidal anti-inflammatory drugs. Well, Terry, let's go to the phones. Lancaster, South Carolina. Who are we speaking to, Terry?
Hi, Chet. How are you?
I'm fine. How are you guys doing?
We're doing well. We understand you're in law enforcement. Is that right?
Yes. And I just wanted to let you guys know the extent of the problem. I'm not in a narcotics unit. I don't specifically look for drugs, but when we arrest people for traffic violations, or you pull them over for not, and you find that they don't have a license or they have a warrant, and you go through their belongings, the number of times that we find giant bottles of prescription drugs is unbelievable. I really think, I don't suffer from chronic pain, and I know that chronic pain is a horrible thing, but I really think that people need to butch up a little bit and not look for this and become addicted to these drugs for the simplest pains. I know there's people out there with horrible pain. Try to find pain management in a different way, because it's killing people. It really is destroying lives. It's got to be costing millions of dollars, and the ease with which people become addicted to these drugs is just unbelievable. We've had people that had bottles, prescription bottles, that held 300 pills that were a week old that had 20 pills left in them. And obviously, they're either combination abusing them and selling them, because that's what this leads to.
Well, what's so interesting about this process, Chut, is that we keep wondering why a physician would write a prescription for 300 pills. I mean, Terry, quite honestly, that doesn't make sense, even for somebody who is in chronic pain. 300 pills at a time, that's kind of out of control as far as I'm concerned. We're
talking about a medication that would be taken once a day?
Exactly, or at most two times a day. And so 600 pills in a bottle, whoa. And so I think that the problem of diversion and the problem of abuse is real. There's no question about that.
Yes, and we really appreciate Chet's perspective on that. Now, we have heard from some people who have been using these drugs for pain, and we've got an email from Rainier. I had finally found the perfect combination for me. I am 60% disabled. I've had surgeries. I've had bone grafts. I was abruptly taken off Norco, that's one of those hydrocodone combinations, and put on Tylenol 3. It made my head fuzzy for half an hour and did nothing for my actual pain. It's really only for short-term use anyway. So why is the DEA screwing up the lives of true pain patients? I was functional. I had some semblance of a life. Now I don't. I can't get rid of the pain long enough to fall asleep or stay asleep. If I don't get enough sleep, I'll get ill. This was a colossal mistake to change the scheduling. So that is Rainier's perspective.
And we'd love to hear from you. The number to call if you have a story to tell or a comment, 888-472-3366. You can email us, radio@peoplespharmacy.com, or reach us via Twitter. It's @peoplespharmacy. So, Terry, let's just for a moment go back to the issue of nonsteroidal anti-inflammatory drugs, because people get very confused. They go, well, if I don't want to take a narcotic, that's too powerful, so I'm going to rely on, perhaps ibuprofen, or maybe my doctor will prescribe Celebrex, or maybe a drug like meloxicam, for example. And so you have to be very careful. If you have high blood pressure, if you have a risk of blood clots, this could be a dangerous combination. And then there are the other NSAID side effects. So we're talking about stomach upset, we're talking about ulcers.
Well, I was going to say stomach upset, definitely, but also, much more seriously, ulcers and sometimes bleeding ulcers, which can be life-threatening.
And then, of course, there's the issue of dizziness and disorientation. There are skin reactions. There's high blood pressure from the NSAIDs themselves, heart failure, tinnitus, ringing in the ears, visual problems, liver and kidney damage. So, these drugs have a long list of complications. Every once in a while we hear from somebody who says, if they invented aspirin today, they wouldn't make it available over the counter. They probably wouldn't even allow it by prescription.
Well, I keep wondering about that because aspirin, and I keep wondering, where is aspirin in the discussion of pain relievers? Aspirin is as effective for pain relief as the NSAIDs.
Well, it's the gold standard.
And yet it's not. I mean, obviously it is used. It is used commonly, but it's not part of the conversation. It does have side effects. Goodness knows. It's got some serious side effects. I mentioned bleeding ulcers before. Aspirin definitely causes bleeding ulcers. But it doesn't cause heart attacks. It doesn't cause DVTs.
Well, in fact, it reduces the risk of heart attacks and what we call thrombotic strokes, strokes caused by blood clots. And it reduces the risk of blood clots in veins, like DVT. So, the bottom line is that aspirin has all of the benefits of ibuprofen, but doesn't have those same blood clot risks associated with ibuprofen. We'd like to hear from you. Have you tried ibuprofen? Has it worked? Some people call it vitamin I, and I think that's a little too cavalier. What do you think, Terry?
That, I would say, is definitely too cavalier. Joe, we do have an email from Linda, who says, for several years, my 70-year-old sister has been prescribed hydrocodone to control chronic pain following hip replacement surgery. Recently, her physician told her he could no longer write her prescriptions because he had to, quote, buy the right, close quote, to write them, and he was limited in the number of hydrocodone prescriptions that he could write, only 100 per month. Some of his other patients were in greater need of the prescriptions, so my sister was no longer among the most needy. Was the doctor truthful when he told her this? And I have to say, I can't answer that question. I've not heard that before, so I really don't know.
I don't either, but we do have a physician on the line from Charlottesville, Virginia. We go to Brandy. Dr. Brandy, welcome to the People's Pharmacy. What's your story?
Hi, Joe and Terry. I thought I had a comment to make, one about the nonsteroidals and then also about opioids like the hydrocodone that you guys mentioned. Selfishly, I don't prescribe a lot of NSAIDs because they do lead to permanent kidney damage. So in my patient population over 65, I tend to avoid them. They can cause NSAID nephropathy that's permanent and could lead to renal failure.
That's a really important point, Dr. Brandy, that we didn't make yet.
And Dr. Brandy, I would have to tell you, I think most people who buy over-the-counter NSAIDs think that these drugs are as safe as can be. Vitamin I. And so if they're a tennis player or if they're golfers or if they like to run or hike, they just pop down this stuff thinking, hey, the FDA made it available over the counter. It couldn't do me any harm. And as a kidney specialist, you're saying not so fast.
Exactly. And that's the caveat, because it is over the counter. Everyone, Advil seems really benign, and that's why people get into trouble, because it does seem benign. But everything we prescribe has side effects, and I hate to sometimes bring up the point as far as prescribing opioids, that people, end up having acute pain, and these medications are addictive. And so to treat that acute pain, we do definitely go to the opioids, but there's a psychological dependence that occurs, and then it progresses to a physical dependence. And really the half-life of this drug is really more like 4 to 6 hours. So if somebody is taking 2 or 3 pills every 4 to 6 hours for a prescription that lasts a month, that number that they're prescribed can become very high.
Now, let me ask you this, Dr. Brandy, because I feel a certain sense of outrage that after all these years, we still don't have really good pain relievers for people who are in chronic pain. So we're worried about the narcotics like hydrocodone or oxycodone. We're worried about the nonsteroidal anti-inflammatory drugs like ibuprofen, like Celebrex, like meloxicam, because they have a long laundry list of side effects. What's a doctor to do when somebody is in really severe pain that won't go away? We lost Dr. Brandy. I'm sorry. Just when I was waiting for the big payoff. Oh, darn.
Oh, Joe.
What a shame. Well, that is my feeling, is like we have been let down by the pharmaceutical industry and by the NIH and the NIMH and all the people who deal with pain, because people in severe pain just don't have very many alternatives.
Well, I'm glad Dr. Brandy explained why someone might have 300 pills in a bottle, and that might not be unreasonable. We go to Charlotte, North Carolina. David, welcome to the People's Pharmacy. Your story.
Hi, Joe and Terry.
Hello, David. What's up?
About 10 years ago, I fractured my back, and I had to go through surgery and everything. And right now, I still take hydrocodone and OxyContin and diclofenac, and I still work. If I didn't take these medicines, I couldn't survive. I'd have to lay in bed, and I couldn't get up, and the pain would be so great. So I don't understand why they would mess with people that want to work.
You have a lot of company, David. I think a lot of people share your perspective. We got an email from Peggy who says, my husband has been taking hydrocodone responsibly for years. Now what will we do? And that is the question.
Exactly.
And will the new law impact you? I'm just curious.
I have to go to the doctor. Well, I go to the pain clinic. And I go to the pain clinic every month to get a handwritten prescription to take to the pharmacy.
And I take it that's somewhat inconvenient?
Sometimes it is, yes, very, because you have to call in advance to go. And if there's a holiday or a weekend, you can't get there. And if you don't call with the 3 days, they say we can't get your refill right now. And it's just a mess, a hassle.
But, David, I take it that's not a new change for you.
No, not really. I've been doing the same thing for a couple of months, or I shouldn't say a couple of months, a couple of years.
Uh-huh.
So I don't know if the new law is going to affect me yet, because the last time I went, they did give me the same prescription, the same medicine, everything, so I don't know.
But I guess the message is, at least in your case, it is possible to take these medications responsibly. You don't increase the dose, and you are able to function in society.
Exactly. I take exactly what I'm supposed to take so I can keep on working and use it right.
Well, thank you so much for the call. We appreciate it, and we get a range of perspectives. Here's something interesting. Terry Joyce from Wisconsin says, my husband, who has taken naproxen for years, was recently diagnosed with a DVT, a deep vein thrombosis in his leg, and multiple large blood clots in both lungs. He was placed on heparin IV and Lovenox, and his platelet count dropped so low that he was at risk for a massive brain hemorrhage. He has a history of low platelets to begin with, and taking the blood thinners put him in a very dangerous zone. This all happened about 6 weeks ago. He's doing well, but this was a life-threatening situation, and we're thankful that he is on the road to recovery. Just suggesting that, again, those non-steroidal anti-inflammatory drugs do have risks that people need to be aware of.
And, of course, if you have found a way to deal with pain that is working for you, we're still interested. The number 888-472-3366.
So, Terry, what are some alternatives to non-steroidal anti-inflammatory drugs for people who do not have severe pain? What are some non-drug approaches?
Well, for people with arthritis, this is going to sound very surprising, but it really is one of the best, is regular exercise. Because when you stop moving those joints, they kind of tend to stiffen up. And so the right kind of exercise, and you may need to do some experimentation, is going to be good. We got an email from Janet in Florida. Curcumin is the thing to take for pain. She also does yoga classes.
Now, curcumin, the yellow spice
in turmeric,
yeah,
which is the yellow spice in curry.
So other non-drug approaches include boswellia. You can tell us a little bit about boswellia.
Boswellia is, like turmeric, is an Indian spice, but it's a resin rather than a root, and it does seem to help people pretty much for, as you say, pain that doesn't require narcotic.
Anti-inflammatory approaches, including cherries, tart cherries, fish oil, pomegranate, and our old favorites, gin-soaked raisins, and Certo and grape juice. And, we shouldn't forget topical NSAIDs. These are drugs that you put on your skin rather than swallow them, and they're available now in this country by prescription. You can get them overseas over the counter. Voltaren gel, for example. You
can put it right on the joint that hurts rather than having to take a pill that affects the entire body.
And, of course, there's old-fashioned capsaicin, the hot stuff and hot peppers.
That's right, and you can find it in some over-the-counter liniments.
We're going to take a short break. When we come back, we're going to find out about vitamin D. And we welcome your calls and comments at 888-472-3366. You can email us, radio@peoplespharmacy.com.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redx Industries, makers of utterly smooth creams and lotions, helping dry, cracked skin feel utterly soft and smooth. The number's 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
You can purchase a CD of this show. Just call 800-732-2334. It's show number 970, or visit our website, peoplespharmacy.com.
We're talking today about the stories behind the health headlines. One of the stories we've been following this week is from the American Journal of Clinical Nutrition. British epidemiologists studied thousands of middle-aged people, following them up for 13 years. Those with the lowest levels of vitamin D in their bloodstreams when they started had the highest likelihood of dying or having a heart attack, stroke, or fracture during that time.
To find out more about vitamin D, we turn to Dr. Tironi Lodog. She's Director of Fellowship for the Arizona Center for Integrative Medicine at the University of Arizona. She's one of the country's leading experts on the science of dietary supplements.
At this time of year, in most parts of the country, the sun is low and not very intense. It becomes very difficult to get vitamin D by exposing skin to the sun. Dr. Tironi Lodog, is it possible to get vitamin D from our diets, or how should people make sure they're getting enough?
Vitamin D is hard to get in your diet because it was really intended for you to get from the sun. and so people in the past who were outside much of their lives, hunting, gathering, working, they had adequate sunshine, and most of them could get enough in the summer months to be able to last through the winter, even in more northern latitudes. This has become complicated now because people with darker skin live further from the equator. It's harder for them to get enough vitamin D through their skin. As we age, it becomes more difficult. We are all very photophobic. We're very afraid of the sun and the damage that it causes, so we wear more sunscreen and skin protection, and we also just spend more time indoors in air-conditioned and heating environments. So vitamin D deficiency has become a real problem, and one that has not been fully appreciated, I think, until probably 6-7 years ago. And even today, we're still debating how much do you need. The the Endocrinology Society has, I think, published some very good guidelines helping clinicians know that they really do need to be checking people's vitamin D, and they need to be getting those levels up to 30 nanograms per mil or a little higher. And so the current recommendations are, 600 to 800 international units per day for most people. It's not enough. It's just not enough. I think most people probably should be taking 1,000 international units per day, but more than that, they should be asking to have their level checked. If they're obese, they're on medications, they have dark skin, they don't spend much time outside, they're 50 or older. I think there's a lot of populations that we're starting to check. And one of the things that you may not realize is that in the pediatric literature, we're seeing that many children who are overweight are vitamin D deficient. And when you then layer on Hispanic or African American children who are overweight, those numbers of vitamin D deficiency, they skyrocket. This is the time children must be laying down good bones to protect them when they're adults. If they're not getting enough vitamin D and calcium, they're going to start at a deficit by the time they reach 25 years of age. Their bones are not going to be as strong as we want them to be, and this is true for both boys and girls. And as you know, vitamin D has a lot more to do than just bones, has a lot to do with immune function, metabolic function. So it's very important. It's more of a hormone than a vitamin.
Dr. Tironi Lodog, thank you so much for talking with us on the People's Pharmacy today.
Thank you.
You've been listening to Dr. Tironi Lodog, Director of Fellowship for the Arizona Center for Integrative Medicine at the University of Arizona. She's one of the country's leading experts on the science of dietary supplements. Her website is drlodog.com. Her latest book is Healthy at Home, Get Well and Stay Well Without Prescriptions. And Joe, we'll spell that last name. People hear it and they're not quite sure what it is. It's 2 words, Lowdog. Not hard to spell, but a little hard to pick up.
And how do you spell Tironi?
Oh, that is actually quite complicated. Tierraona, Tironi.
And, of course, Dr. Lodog has an interesting heritage. The Tironi comes from her Irish ancestors.
Correct. And Lodog comes from her Lakota ancestors.
Right. What's your approach to getting your vitamin D? Tell us about it. Our lines are open at 888-472-3366. You can join the conversation by sending us an email, radio@peoplespharmacy.com, or via Twitter @peoplespharmacy. Again, do you have experience with vitamin D? We'd like to know about it. Again, 888-472-3366. And we're going to take a few more calls on pain relievers. Let's go to Kurt in
Minocqua, Wisconsin. Kurt, welcome to the People's Pharmacy.
Hi, Joe and Terry. How you doing?
We're doing well. What's your story, please?
Well, I've had chronic feet problems for 20 years, and then I had plantar fasciitis, and I had surgery, and that bunked up, and I got stress fractures in my feet. I've been taking opiates for a good solid 15 years now, and if I wouldn't have been taking the opiates, I wouldn't be working at all, or I'd be doing nothing. Now I work 10, 11 hours a day, and I live a good life, can support my family and everything. And sometimes you feel kind of bad, though, because if you go to another doctor or something like that, and you tell them what medication you're on, it's almost like people frown upon you, like, because you're taking these drugs, you know. So I think there's like a stereotype out there where people think, oh, well, you're a drug user, you know. And for me, it's saved my life, you know. I can work every day and support my family.
Kurt, thanks so much for your perspective. And I know for sure that you are by no means the only one who has had this really good experience with using opioids responsibly.
And I just wish people recognize that there are a lot of folks in severe chronic pain who need something to be able to get through the day. You know, we wouldn't let an animal suffer. Why would we let a human being suffer? Let's go to Dr. Carol in Naples, Florida. You're a physician, Carol. What's your story?
Yes. Well, hi, Joe and Terry, and thank you for your show. I listen every week, and I always learn something. So I work in a functional medicine practice where we try to look for underlying causes instead of just sweeping things under the drug, as I call it. And the people with chronic pain frequently have food sensitivities or a diet that is pro-inflammatory. And if they look to that, they may get 50% relief from their symptoms, maybe even more. The most common of the food allergens is wheat. So if you simply eliminate wheat from your diet, you can see if you get a little better. Then some of the oils, fish oil, for example, is anti-inflammatory and has actually been shown to be as effective as Tylenol in relieving pain. So these are some of the dietary strategies that could be used.
Well, Dr. Carroll, we really appreciate that.
And, you know, this idea that we eat a lot of pro-inflammatory foods, especially those omega-6 fatty acids, I think we haven't appreciated the severity of that situation. Thank you for sharing your perspective.
You're very welcome. Thanks for talking to me.
Bye-bye.
And, Joe, before we leave the question of pain relievers altogether, we've had a few emails who have commented on how many of these pills are dispensed for an acute pain situation. So Charlotte, for example, said, I just had gallbladder surgery and I took the pain pills for 3 days, but now I have half a bottle left and also half a bottle from the original ER visit before the surgery. I understand that there are lots of people in chronic pain, but there are also a lot of us who get these pills for an acute situation, don't need all that we're prescribed, and then have them sitting around. It's really hard to dispose of them responsibly.
That's a very good point. Let's go back to the phones. We're talking about vitamin D now, and we go to Terry. Where is Nancy?
Sharpsburg. Is that in Maryland, Nancy?
Yes, it is, Joe and Terry.
Excellent.
I thought I would contribute. I have experience with vitamin D. I had just a routine visit with my primary care physician. He did the essential blood work and found that my serum calcium was going up. He was concerned, sent me to an endocrinologist. He checked more blood and found that my vitamin D was very low, and that the rise in the calcium was due to a defective parathyroid gland. But he immediately put me on vitamin D. So I've had good results. I ended up having to have the defective parathyroid removed, and the calcium immediately went to the normal level, and I've been on vitamin D ever since. And so so I tell everyone that I know, please get these things checked and keep on top of them. And I'm one of these people that I have sensitive skin, used a lot of sunblock and things like that. And so I guess I just wasn't getting enough from the sun. Well, I know I was, and I'm in my 70s, so I'm one of those older people too. But vitamin D is very important, and
It certainly is, and we really appreciate your point. Not only is vitamin D important, but it is true that if you use sunscreen conscientiously, as we are supposed to do, you may not be making the vitamin D that you need through your skin.
And it's not just older people, Tara. I mean, there are a lot of young people out there who are getting way too little vitamin D because, A, they're not spending very much time out in the sun. If they are, they're wearing sunscreen, and they may not be consuming foods that are high in vitamin D. Let's go to Cary, North Carolina. Hi, Josh. You're on the People's Pharmacy. What's your story?
Hello. Yes, I had found out really about the sunscreen and how it, doesn't allow you to get your vitamin D, and I've been going out getting about a half hour to an hour a day out in the sun where I go and exercise with shorts and, sometimes take my shirt off as I'm exercising, and I have noticed just feeling much better getting more sunlight. And I haven't had my vitamin D checked, but I would imagine that it's doing much better. And I'm real pleased with getting it naturally from the sun. And I think the whole thing with the sunscreen, I think, is overrated. People are afraid to get out in the sun, and I'm not afraid anymore, and I just get out there, and I feel good.
Well, all of the dermatologists who are listening are cringing and frowning, and if they could see you, they would probably spank you.
They're throwing tomatoes at their radios.
Right.
There is a place, no question, for sunscreen, but there's also, we think, room for people to get their skin exposed to sunlight for limited periods of time. And of course, the problem is at this time of year, that's not practical in probably 2/3 to 3/4 of the country.
Well, I'm sure our friends in Wisconsin, for example, today are not going to be getting very much sun exposure.
Not going out in their bikinis. So,
no. But
Joe,
thank you so much for your call, Josh. We appreciate your perspective.
There was one other topic that we wanted to mention on the People's Pharmacy today. It's Movember.
It is Movember, and if you see a bunch of guys all of a sudden growing mustaches, you might ask them, well, what's that all about? Well, it used to be No Shave November. It has now been changed to Movember. It started in Melbourne, Australia, some time ago to increase the public's awareness and understanding of common men's health problems. Prostate cancer, testicular cancer, and mood problems. Mental health issues. So if you see a guy with a new mustache, pat him on the back. Congratulate him for celebrating Movember. If you're a guy, you might want to start growing a mustache. And while you're at it, you might want to contribute because, women have been very proactive when it comes to women's health, especially the pink ribbon effort for breast cancer. Men have been kind of, what would you say, Terry, a little lackadaisical about their health.
I would never say that about men.
Well, I think it's probably true.
But there are data suggesting that men are less likely to be conscientious about seeing their doctors and following up on symptoms.
So go to the website. We have a link from peoplespharmacy.com, but just put Movember, Movember, into your search, and you'll find out a lot more about this movement. We support it. Do you have any other emails?
Well, I do, actually. I've got an email from Elliot Fix who wants us to know and tell everybody that if you are taking supplemental vitamin D, which is not a bad idea, you should also be taking vitamin K2 because that helps the vitamin D get the calcium where it belongs.
Well, I barely have enough time for a rant, but may I get up on my soapbox?
I can't keep you down.
All right. Well, several years ago, we brought to the attention of the Food and Drug Administration a generic form of bupropion, an antidepressant The original brand name was Wellbutrin XL300, and after many, many years, the FDA finally said, okay, you're right. Budeprion XL300 is not bioequivalent to the brand name, and they had it removed from the market. Well, just a few days ago, the FDA admitted there's another problem with the generic product. It's methylphenidate extended release. Now, you may remember methylphenidate was originally for ADHD. It was under the brand name Ritalin.
Right.
But the newer product is Concerta. It's an extended release methylphenidate. The FDA says, although we approved 2 products, generic, they really may not work as well as the brand name. So if someone you know is taking methylphenidate extended release from Mallinckrodt or Cudco, Kudco, they may not be up to snuff.
So is this an oops
this
from
is
the
a
FDA?
Big oops from the FDA. I don't know that they actually said oops, but we think it was a big oops, and it raises more questions about generic drug approval quality.
Now, the FDA says there is one generic Concerta on the market that is fine, and that's the one that Actavis is selling. Because
it's an approved generic.
It's an authorized generic.
Authorized by the company that makes Concerta. Well, that's all the time we have today. No more ranting and raving. If you've got a question and want to share, all you need to do is go to the website, peoplespharmacy.com. Thank you so much for listening today. Lynn Siegel produced today's show. Sophie Copeland provided technical assistance. Al Wodarski is the engineer. Dave Grayton edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
If you'd like to order today's show, you can call 800-732-2334. Today's show is number 970. That number again, 800-732-2334. Or you can find it on the website, peoplespharmacy.com. When you go to the site, you'll have an opportunity to tell us what you think about the show or find information about prescription drugs, herbs, and home remedies.
You can also subscribe to the free podcast of our show through iTunes, and next week you'll be able to sign up on our website.
Actually, you can do that now.
Right this very minute. You'll still find us always at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Grayton.
And I'm Terry Graydon. Thanks very much for listening, and please do join us again next week when we'll be talking with Dr. Jeffrey Bland about the disease delusion.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.